on Teams, you can't actually see what you're doing, can you? It's horrible.
Mm-hmm.
So apologies, everybody. I'm not going to present on burns. I'm not clever enough to wing that at the last minute. This was a talk that I delivered at the ARCM conference last week, and so I thought it would be quite useful just to give this, to start you thinking about some things in your emergency departments and how you look after patients who definitely present to your EDs, because I know they do. As we're going through, I'm going to pause asking you some questions, but because of the nature of this, there isn't the opportunity for you to vocalize what you're thinking. But perhaps if you just note down yourself what your next management would be, and obviously reflect on that. So it's not I'm going to stop and give you a question, you give me an answer. It's for you to pause and reflect.
Caroline, sorry, just before you go, could you click again on your presentation icon, or press F5, because it's still on the sort of how you're looking at it as a screen rather than a whole presentation.
What does that look like?
The same.
No, it's still the same.
Try F5 to make it full screen.
Did that work?
It doesn't want to.
I hate Teams.
Oh, I hate Teams too. I'm glad it's not just me. Not to worry, we can still see it. You carry on.
Okay. And so you can see it just looks small and rubbish. Is that what we're saying?
Yes, that's correct.
Okay. Okay. Yeah. Say again.
Not rubbish.
Oh, right. Okay. All right.
Well,
So,
sorry, I didn't mean rubbish. I just meant small.
no. I don't take that personally. Okay. So let's focus, everybody. So we've got a trauma alert coming in, and it's a 78-year-old male who's fallen from standing and sustained a head injury. You've got the observations there, and of note, you can see that the GCS is 9. Treatment-wise, it's just a normal paramedic crew. They've said he's maintaining his own airway, he's having oxygen, and he's obviously been spinally immobilised with a collar and scoop. Got IV access, and they're going to be with you in 10 minutes. So obviously, you're going to put out a trauma alert. You're going to assemble your trauma team and get roles together, and you're probably thinking straight away, this guy's definitely going to have a CT scan. And you might be thinking, is it going to be CT head and cervical spine, or actually, because of the reduced GCS, does this patient need a full body scan? So that's something that you could reflect on, how you would operate in your own departments. So one of the nurses says to you, do you want to draw up TXA before the patient arrives? And obviously, in that case, there was no bleeding of that patient at all. There was no sort of evidence of hypovolemia. So what they're really asking you is, are you going to give TXA for a patient with traumatic brain injury? So that's the question. So we're going to assume that they are within 3 hours of injury, because if it's more than 3 hours, we shouldn't be giving TXA for anything really. So for this patient, assuming they're within 3 hours, will you give TXA? You've heard that the GCS was 9, and it's a 78-year-old male. So just have a reflect on that. So I'm going to say yes, but let's talk through what the evidence is. So this was the CRASH 3 trial, which was published in The Lancet in 2019. And overall, if you look at this figure here at the bottom, there was no statistically significant benefit from giving TXA versus placebo in patients with head injury, because you can see that this line here crosses 1, which is the line of no benefit. So this is it's good, and this is it's bad. So it crosses 1. So overall, that's what the results showed. But when you looked at subgroup analysis, so mild to moderate head injuries, there was a definite benefit, which was significant. So no lines crossing 1 there. Now, what people argued is that it's wrong to look at a study and base recommendations on subgroup analysis, because in that subgroup, your study may not be adequately powered to be able to detect a true difference. That might not actually be a true result. My thinking of this is that TXA costs £1.20. It's very easy for us to give. And in all of the trials so far, TXA has not been demonstrated to show any harm. So for all of these patients that come in with head injury that have a reduced GCS, so starting with a GCS of 12 or less, or who have a positive CT head and I can give it within 3 hours, I personally would give it to a patient. The NICE head injury guidelines are being revised at the moment. They're coming out soon, and I'm going to be really interested to see what they recommend regarding the findings of the CRASH 3 trial. So this is the primary survey. The patient's arrived. The paramedics handed over. There's nothing really extra on that handover. And your team have now completed the primary survey, and they've pretty much found it looks like an isolated head injury. Of course, very difficult to tell, but that's what it appears to be. There's the observations, and the GCS you've got as 5, with the pupil size 5 and sluggish. Obvious signs of a frontal head injury. The crew handed over to you that they've definitely seen movement of the arms, but not obviously of the legs. And there's no other obvious injury, but bearing in mind, obviously, this is an elderly patient. We know that these sorts of patients can have lots of injuries, and we're not very good at detecting them at clinical assessment, and especially in someone with a reduced GCS. So the next question is, will you RSI this patient before you transfer them to CT? So again, just reflect on that. So a 78-year-old male, he was maintaining his own airway, he was maintaining oxygen saturations on 15 litres of oxygen. So have a think, for this case, are you going to RSI? And I'm going to say yes. So, and it's not because of the GCS thing. So lots of people go, if your GCS is 8 or less, definitely you should be intubating. I don't think that's true. I think it's much more complicated than that. So this patient is maintaining his own airway, but it's likely that with that low GCS, he's lost his protective laryngeal reflexes. And so this patient is at really big risk of aspiration. And no matter how far away my CT scanner is, which for UHGW, you know, is in the ED, aspiration can happen at any time. And once it does, we can't go back from that. Okay, so for that reason, I think it's important to optimise things properly. The patient is maintaining oxygenation, but what is their PaCO2? And here we're thinking about prevention of secondary brain injury. So we want to try and keep everything normal if we want to optimise patients' outcomes. Now, you could be saying, well, he's 78, he might not be suitable for ICU, he might not be suitable for neurosurgery. This could be a futile case because the GCS is very low. It's not looking good, is it? But my thinking is, we can work that out later. We can find out more collateral history from the family. And if we intubate now, we can extubate later. Okay, so it's not we've intubated, we've set the course of what's going to happen running next. Anything can change. So I would personally intubate that patient. When I gave that talk at the RChem conference, one of the questions was, would you put in a laryngeal mask airway, a supraglottic airway device? Well, if you're giving an RSI, which we are in this case, we would just go for the gold standard airway. So next we need to think about preventing secondary brain injury. So the way that I like to think about this is you just keep everything at normal. So you don't want to avoid low levels, but you also don't want to avoid high levels. So thinking about, is our PO2 in a normal range? Is our PaCO2 in a normal range? And this is a patient who's not obviously coning at the moment, so that's why we're using those targets of 4.5 to 5. Is our blood pressure in a good range? Is our blood glucose normal? Is our temperature normal? Okay, and if any of those are deranged, then there is a risk of secondary outcome not being very good. Then we need to think about positioning. So can we tilt our whole trolley with a bit of a head up tilt? Very, very difficult to do. Can we check the tube ties, not squashing the neck and reducing venous return? And do they actually need to wear a collar? So our routine practice at Coventry would be to take the collar off and maintain manual inline stabilisation with blocks on, or in our case, in a vacuum mattress. We want to treat raised ICP. This patient doesn't have that at the moment. Well, no evidence of it on clinical signs. If they have any seizures, we treat those. And if there's any coagulopathy, we treat those. So we've got a bit more history now. We've got an ample history. And you can see the patient's got no allergies. They're on antihypertensives and, oops, they are on a DOAC, okay? They last ate and drank at 0700 hours, and the history is they slipped on the drive, they hit their head, and they had loss of consciousness. So as you can see from my notes below, the elimination half-life of Roxavan is 5 to 9 hours in the young, or 11 to 13 in older patients. But if you have poor renal function, it can be over 24 hours. So some people say ask what time they took the DOAC, and then obviously that might change whether or not you reverse it. I think in most cases the haematologist would advise reversal anyway, just to be sure. Now, in the future, in the very near future, we will be able to, in our own labs, detect the presence of whether there's any circulating levels of drugs like this in the blood, because if there isn't any levels in the blood, then obviously we wouldn't need to reverse it, which would be very helpful. So how are we going to reverse the rivaroxaban? Okay, and it's a factor 10A inhibitor, and that's why it's got the XA in it, which is very helpful. So essentially, lots of the DOACs operate via this mechanism. There are antidotes that you can buy, but they cost £15,000, which is a bit excessive, and they're not readily available at the moment, and they're not really licensed for traumatic brain injury. They're more for GI bleeds. So we're going to provide an indirect reversal, and these are the options that you've got. So I want you to choose. There's only one right answer here. How are you going to provide indirect reversal of the rivaroxaban? So the correct answer is tranexamic acid and prothrombin complex concentrate. The TXA, if you haven't given it already because of CRASH 3 trial reasons, you're going to give it now to reverse or indirectly reverse the DOAC, and that is not dependent on time now. We're not talking about whether or not it's within 3 hours, you're going to give it anyway. Then the prothrombin complex concentrates, that's got 4 factors in it, 2, 7, 9 and 10, as well as protein C and protein S, so that's going to boost your factor 10. We're giving that at much higher doses than we would normally use to reverse warfarin, so it's 50 units per kilogram for the first dose. And commonly in your departments, that would be Octoplex or Beriplex. It costs around £1,500 per dose, okay, so it's not a cheap thing. But essentially what I want you guys to do is think, where do you keep that in your department? Do you have to get that from blood bank and wait for it to come down? So there's going to be massive delays. Then it takes quite a long time for the nurses to draw it up. So that's a really good quality improvement project for people to do in trauma units or in LEHs. If you don't have it in your department readily available, could you work to get that done? And certainly I can share with you the work that we did at Coventry to get that done. So our patient has now gone for we've gone for a whole body CT scan at Coventry because it's really easy for us to get. And unfortunately, it's shown that this patient has a devastating traumatic brain injury. So you can see straight away, you don't need a radiologist to show you, that does not look good. Okay, so you're thinking this is quite possibly going to be palliative care. There's no other significant injuries on the patient. They've got a couple of rib fractures, but other than that, nothing else obvious. But of course, you're going to get the full report through in a bit. So the next thing we need to think about now is we need to get some social history, and we need to think about assessing futility versus active movement in this patient. And to do that, of course, we're going to need to get some more information from the family about what is the patient's normal quality of life. So this was a study that was done by the London Trauma Group, and they were looking at 3 different frailty assessment tools by ED nurses in trauma patients. Okay, so they were just looking at, is it feasible? So can you complete the whole frailty assessment easily in that environment? And is it accurate? And they were comparing it to the gold standard of a geriatrician doing a frailty assessment within 72 hours of admission. And the findings were that the most useful tool to use, the most feasible, as in it got completely completed by the nurses, and the most accurate, so the most likely to be the same as the geriatrician later on, was the clinical frailty scale, which is the Rockwood score, which lots of us are using in our EDs anyway. So if I just tell you about this patient, there is a clinical frailty scale app, which actually Tom Odbert from Northampton pointed me towards. So if you're not sure, you can download the free NHS app. And if I tell you that this patient, essentially, he walks with a stick, he can wash and dress himself, he needs his daughter to take him shopping, and he also employs a cleaner to help him and his wife at home. So what is his clinical frailty scale? So I am going to give him a clinical frailty score of 5. So to start at the top, he's not terminally ill. Now, remember, we're using what he was like 2 weeks ago, not what he's like today, because he's not looking good today. So 2 weeks ago, he wasn't terminally ill. He wasn't completely dependent. So that's not dependent on personal care. He doesn't need help with everything. He can wash and dress himself. He can cook dinner, but he does need help with ADLs as described there. So he is a clinical frailty score of 5. And the point of this is that frailty is probably much more useful than age when we're thinking about futility in trauma patients. And this was a study that was published last year, and it shows obviously the outcomes dependent on frailty score in patients over the age of 65. So this was done in Bristol. So clinical frailty score of 1 to 4 is considered not frail. That was the reference standard. 5 to 6 is obviously the more mild end, and those patients had 5 times the risk of dying after major trauma. And clinical frailty score of 7 to 9, obviously 10 times the risk of death. And that was any cause of admission. So, you know, that's a lot of patients that are coming in with varying issues. So I think when we're communicating about should we treat this patient, should they be transferred to the MCC, clinical frailty is probably a very useful thing for us to incorporate into our handovers. So it's been discussed with the neurosurgeons at Coventry, and they've advised that this patient would not be for neurosurgical intervention. We know what their function is. So their function is not bad at all. They're a clinical frailty scale of 5, but this is a devastating brain injury. There's no question about that, and the prognosis is extremely poor. But in front of you, you've got a patient that is intubated at the moment, and the family are not here yet. And so the question is, will you admit that patient to ITU, or will you extubate in ED? Okay, so that's the 2 options really. So have a think through what you would do. And I don't think there is actually a right answer. It's going to depend on numerous factors. So you could argue that it's not appropriate to send this patient to ITU. Our beds are very, very limited. It might give false expectations of hope for the family. And actually, you know, it's particularly with COVID and everything else, you know, is that appropriate? But you could also say that actually it's very helpful because, first of all, you freed up space in A&E resus straight away. It's going to give the family time to come to terms with what's going on. It's not going to be rushed end of life care pathway. We could consider organ donation in this patient. And, you know, it may actually be more appropriate to deliver that care in that setting, dependent on beds. So if you don't have this scenario commonly, it's worth having a chat with your ITU teams and making sure that there's a shared mental model between ED and ITU and what we do with patients like this. And this document here, if you haven't read it before, it's really, really worth reading. And this applies to all ages of patients. So this is a patient where you can see that they have a perceived devastating brain injury on the CT scan, extremely unlikely to survive. What should we do with those patients? And this document does encourage transferring patients to ITU for neuroprognostication, organ donation consideration, and unrushed end-of-life care pathways. Okay, so that's all from me. Hopefully that was useful. Sorry it wasn't anything about bends, and I'm happy to take any questions.
Thank you, Caroline. I think there would be a lot of questions. I think this is a problem that at least the smaller hospitals come across very frequently. And as you know, we had quite a few chats regarding the futility decision and end of life, which is not something simple that you want to do on the everyday basis. But I've got a bit of a trick question. You are discussing about the TXA for the reversal of the rivaroxaban, which is, yeah, that's absolutely fine. How does that come into the CRASH 3 trial if you go for more than 3 hours post-injury? Because the CRASH 3 trial showed that if you go down the line, actually, TXA increases the mortality. So you would still give it to try to revert the rivaroxaban, but how would that balance with your mortality increase from CRASH-3 trial?
Yeah, so it's a risk-benefit analysis, but in the majority of cases, we're only thinking about this for people who have life-threatening bleeds. So this guy has a life-threatening brain bleed, so that would outweigh it in this patient. So you're right, but if you're trying to reverse something, they would say TXA at any stage for DOACs. Now, if you think about GI bleeds, so HORTIP trial showed that it's not good to give TXA. In fact, it's very bad.
Yeah.
However, if that was an MHP patient and we're shoving in blood products, we will be giving them TXA because we want to give them that for their fibrinolysis. So it's how you're using it is different. So if we're giving an MHP or we're reversing agents, then we're giving them for a slightly different reason.
There's a question for the public. If the patient was on warfarin, how would this affect the use of TXA, the reverse of life? Would you still give it? If it was a rivaroxaban, was it TXA? And let's assume, for the sake of argument, that's 5 hours down the line.
Okay, so you do not give TXA to reverse warfarin.
You don't.
Okay, so we would give vitamin K, 10 milligrams IV stacked, and we would give prothrombin complex concentrate, so the ultraplex, the variplex. And the dose of that we'd give for those patients, you'd try and see if you had a recent INR. And if not, you'd go, if the INR was 2, what would I give? You'll give that dose, and then you'd obviously recheck the INR and check that it would come back down to normal. So no, we don't use TXA for reversal of warfarin.
Yeah, but would you still give it, let's say, 4 or 5 hours down the line for the TBI?
No.
No, it's a very frank, very categorical no.
Yeah. Definitely, because in that study there was no benefit and potentially harm after the 3 hours.
I completely agree, but I think we need to make this these points loud and clear.
Yeah.
For everybody to be on the same page.
Yeah.
Of the lack of benefit after a certain amount of time, and in the absence of any indication, any proper indication for it. What about intubation? Because again, that's another discussion in a major trauma center versus TU. Because in TU, every hospital in the trauma team has an anesthetist, which is depending, registrar or consultant, and those discussions will be started very early about what are you planning to do, because it's one thing you intubate and then you take it from there, which I personally love that and I agree, but many times you've got discussions around why intubate at all, and if you suspect by default a significant brain injury, is there an actual need of intubation, or would you just move forward and make clinical decisions in the range of the futility if that's the case?
So if the patient was from a nursing home and you knew straight away that they're in a nursing home and they're dependent on all care, so they're going to be clinical risk of 7+, or you get more information, they're hoisted, they're wearing pads, and they come in with exactly that story, then I'm thinking that the majority of UHCW consultants would not intubate that patient, because 100% they are not going to be for ITU or neurosurgery, 100%. Like, we know that. Or if they're 99, for example, with that sort of story. However, those patients who have obviously been out and about, this guy was walking on his drive when he's had a fall, then he may be for neurosurgical intervention. Okay, so at that point we go, if they are, then we deserve to give them the best chance we can at the earliest stage. So whether it's in the pre-hospital environment, they'll be intubated, or if as soon as they arrive in ED, there's no point in having a half-hearted effort with these guys. It's either all or nothing, in my opinion.
Yeah, I agree. Right. If there are no other questions, let's thank again Caroline for filling in. I think there's something coming to the chat right now. No, it's just a thank you.
Answers. I'll type some answers.
Yeah, definitely. Thanks a lot, Caroline. And let's move to our last session of the day, to Nicola Dixon, who will speak with us about spinal care post-admission. Nicola, can you hear us?
Hi, I'm with
Hello,
you.
Nicola.
Hi, let me just organise this.
Take your time.
Right, has that appeared?
Not yet, I can't see it.